Hi, it's Jenny back from Nowheresville, America, in her hillbilly state. You know me, I just love to get me some chart auditing going on here. Just an FYI, I used to do a lot of chart auditing as one of the part of my job. What I did, I had to do it also basically for safety reasons, regulation reasons, and also communication back and forth to the insurance companies. They would do whatever they can to always say decrease the payments, length of stay, yada yada yada, and I always had to find some other reason, and they were always valid as to, just so that they would pay us at the rate, and also they would pay us just to make sure that these babies would stay, or and adults too would stay, for the correct amount of time that they need to. So just as a background information, just to kind of rehash, baby E was a twin, an identical twin with twin-to-twin transfusion, and it had umbilical cord blood flow issues with it too. So it was not a baby that was born in good condition. Okay, people, it had extreme stress under. It happened even before delivery. Mom also should have been delivered and had planned to deliver at Liverpool Women's Hospital because there was no room at the inn. She was put at the Countess of Chester. And this will be part 2. There will be another part with baby E. There's a lot going on too. And just and again, if you want to get more in depth, just look at my previous video. Basically, the baby had at minimum 2 pretty big bleeds, GI bleeds. In addition, probably a bleed a couple of hours prior to this that was showing the sign. And then during the resuscitation, when they do those chest compressions, what they're doing is that they're putting pressure and, to make the heart beat, but it's putting pressure on its little tummy. And that's just forcing all that blood that is just in that stomach to come out. And it was just coming out of the baby, and it sounded like a bloodbath. So what we're seeing here, right here, and this is part of brewery, he had made all these reports to make everything just look fine in day and A to cover his ass and the unit's ass. And this is to be presented at various things in and out of the hospital and meetings. So I'll just kind of go with it here. Okay, so basically I have a concern right here. What does it say? That's basically each child is assigned, as it should be, a consultant, and this consultant would be, kind of the consultant during the day, was assigned to it if there's any special paperwork done or anything that needed to be done. Again, this was essentially the buck stops here consultant, and it was, oh God, John Gibbs, a man who does not know how to practice medicine in the 21st century. He is still practicing medicine as if he's back in the 20th century. All right. And then the resuscitative consultant was Dr. Z.A. Again, as we all know her. Oh, don't get me started with her. That was the one that, toddler Ollie died due to. Basically, if she had just kept the baby in overnight, it was a toddler, or just given it some just basic penicillin, the toddler would be the healthiest, biggest, most robust 8 or 9-year-old boy you would have ever seen, and enjoying life. And probably, to me, my 8 and 9 years, when I was 8 and 9 years old, was probably one of the happiest times of my life, and as it should be for any child. But of course, now he's no longer with us, and that is why she was anonymous under the thing, just to protect her worthless ass. It looks like here, okay, the gestation here, this is, I think, with the date of birth. It just shows the baby was born at 5 in the evening. Gestation was a 29-weeker out of 40. Now, this isn't just any 29-weeker. You can't think of it as your run-of-the-mill 29-weeker, which is premature, which is not good. It's a one that didn't grow right, didn't get all the blood it needed. It was sending its blood to its identical twins. So you have to look at it 29, and you have to put an asterisk to that too. Again, when I did chart auditings in my neonatal unit, every day the neonatologist would write a really wonderful head-to-toe assessment on the baby, and also what happened in the last 24 hours, and then the plan of care for the next 24 hours. Well, 24 hours, week, month, whatever. But always began that, and every day it did. It didn't no matter if the baby was there for 2 hours versus 2 months. Always included the obstetric history as a way to remind him or herself of how stable this baby was prior to delivery. Now, reason for admission to the unit, prematurity, okay, so in this REDF, it's basically just says, it's code for, there's a blood flow issue in the umbilical cord. And that, let me tell you, reverse end diastolic flow, that is huge. I see that on a chart, and again, I did chart auditing on the antenatal floor, which is the pre-delivery floor. I looked at that and I went, oh God. And then I would look at who the consultant was, and it was always, I don't want to name his name, but it was always the one, it was our version of Dr. Martin Pittman. Wonderful. And always had wonderful outcomes. And again, one of the reasons we had incredible outcomes in our neonatal unit, obviously due to the neonatologists, excellent neonatal nurses, but more importantly was the fact that we had a Martin Pittman taking care of these babies prior to they were born and keeping an eye on them like a hawk. Now, day of death and age, so it looks like the baby died on this date, and it was 1 o'clock in the morning. Cause of death is neck. Just keep that in mind. Of course, they always have to put Lucy Letby in it. And these basically are part of the things that we found in Thirlwall. These were the various reports the brewery would do, I guess both in and out of the hospital, the board things and the meetings, just to prove that, he had the world's best neonatal unit instead it was just a piece of shit. Again, what scares me here is Dr. John Gibbs, the resus there was Dr. Z.A., and the registrar is Dr. Hawkness, of course. This is a gentleman who cannot think on his feet. This is a fourth year. 4 years after graduating med school. This man should be able to think on his feet. And I can guarantee you that long before he came to the Countess of Chester, there were signs. There were signs that this man couldn't think on his feet. In an emergency situation, he had major screw up on baby A. And there will be other babies that I will explain to that he screws up on too. And you know what? That's okay. We all panic. We all have to make sure that we are in the right job for safety-wise. I personally would have never thought of myself of ever even considering being an intensive care nurse, an A&E nurse, yet let alone a neonatal nurse. I knew what my strengths and weaknesses were, and I stayed where my best qualities were. But more importantly, my managers knew that I was right for the job. And I am really wondering, and this long before he showed his face at the Countess of Chester, there had to have been signs that this man was not in the correct pathway, that someone should have done the correct action and said, no, taking him aside, this is not the right job for you. Let's look at some other pathways. And there's some wonderful, absolutely wonderful areas in medicine that you could do that would not involve an emergency situation. And he may have been perfect for that, and it would have been the best thing. And the best thing that you can do for a person that is under you, that you're in charge of training or managing, is to guide them into that correct pathway. And it's the kindest thing you can do for them. And obviously someone was not thinking, just, passing them on. And I have seen this, rare, and I have seen many of them that were just basically, okay, nope, this is not right for you. You're going someplace else, which is right. But I've also seen, and the way he acted like a first year, but a rare first year. Many of the first years that I had in contact with, man, they could in an emergency situation until that, just say more seasoned register would come on. At first couple of minutes, they could handle it. And then there was I remember one instance that, and I believe this guy was fresh out of med school. Good guy, absolutely good guy. A patient collapsed right in front of us and coded, and he just panicked and stopped and froze. Thank God that nurse that had that patient, I did not. I was kind of this, I came on the scenes like just seconds later with the crash cart. Knew in an instant what was going on, what was going on with him. We understood. She grabbed the laryngoscope, which is the tool you need in order to what we call intubate someone. You have this metal tool that you put in their mouth and their throat, and that guides that tube into you can put it in the windpipe and you can start the resuscitation you need. And basically threw it at him. She didn't aim it at him, she aimed it at the bed and screamed to the top of her voice, "Intubator!" That knocked him right out of his panic correctly, and he did it. And let me tell you, she got him through. Lovely nurse. I remember her. Wonderful nurse. Got him through his first code. And I bet he was okay after that. Again, that first time, you would expect them to panic. And also, the alarms are going off, and that code team came within minutes, and unfortunately, the patient did not make it. She was an older woman with many issues going on with her heart, and it was her time. But you know what? We did everything we could, and thank God she had an incredible nurse and also a good trainee doctor too that just needed that to be pushed out of his a panic situation. And get through it. And again, probably his next codes on, he probably just did it fine too. And you know what? I can guarantee you, he appreciated the fact that nurse did that. And I have this feeling, and Dr. Hawkness, I'll explain his testimony later on, but what a bastard, an absolute bastard in what he had said in his testimonies, covering his own ass. No excuse, no excuse. That doctor, I bet Lucy was saying to him, blood, we need blood. Can we get blood? And again, as a nurse, we're not allowed to do that. But what we do is we, shall we say, suggest to the doctor in a way that they can't say no. And they always, 99.999% of these trainees, in fact, would say, come back and say thank you. We've had that. I've seen that happen. And they absolutely appreciate that. And we as nurses are doing our job. We are trained to do this. We are trained to understand a physician's strengths and weaknesses, and we are also expected to self-reflect ourselves and realize what our strengths and weaknesses are, and to guide ourselves into a correct position. Again, I probably would not have made a very good intensive care nurse. I made a pretty good floor nurse on a medical surgical floor, and I made a really good chart auditor too. So let's go back to the chart auditing. It says August 3rd, GI bleed. Okay, now let's look at this blood gas here. Okay, it's 10 o'clock. That is what, hours before this baby dies? That is an acidic, that pH there is acid. It's 7.22. It shouldn't be anywhere near that. What is that saying? It's telling me that baby is probably in metabolic acidosis at this time. Those those little cells in that little body, they're dying. They're being starved of oxygen, being starved of what it needs, being starved of blood, being starved of whatever. The end product always is acid. Acid is not good. Okay? Baby was dying. That was the start of the death right there. So 11 o'clock, GI bleed, it's 13 mils. That's huge on that size of this baby. But what it's not showing us is the fact that there was I think a 15 mil one later on. Of course, Brewery is lying by omission. And again, they're doing CPR in this baby, and they're doing chest compressions on this baby. Boom, boom, boom on its chest. And what's happening is that's putting pressure on his little tummy, and his tummy is full of blood. So what's coming up is that blood is coming out, spurting out. So, and by the description of this, it's an absolute bloodbath. It was probably blood everywhere, all over the incubator on this. And every time they're pressing on this thing, it's like blood is squirting out. So this baby, even though they say it lost a quarter of its blood, They're estimating it probably lost to half, if not more. A lot of that blood was still remaining in the GI tract because you can't what? Put your finger on the dike. And often, if you would do a post-mortem on these people too, they'd open up that little intestinal tract and that little stomach, and there'll be just a huge pool of blood. So it says here, sudden collapse, bradycardia, desaturation, emergency intubation. Well, yeah, sudden collapse, bradycardia means the heart is slowing. It's because it's not getting blood. So, of course, he's saying here, satisfactory record of nursing observation, blood gases, and medical and nursing entries. Okay. Appropriate actions after deterioration notice. Oh my God. We're going to call bullshit on that. I think even the village idiot would know that this poor baby needed blood, and needed blood long before it died. It didn't do it. And it says questionable delay in elective intubation between 11 and 11:40. So it took him between 11 and 11:40 to figure out that the baby needed to be intubated. It's 40 minutes period, people. In an emergency situation, you have 40 seconds, okay? 40 seconds. So let's go to the third one here. Necrotizing enterocolitis, prematurity, no postmortem. And no postmortem is because Dr. ZA, we're going to have a discussion with him about her on part 3. She convinced, now of course she just mentioned to the parents in a kind way, I don't think a postmortem would help, but of course the parents stressed out. They saw this baby freaking bleed to death. And of course they're going to say yes. They absolutely, under no circumstances should she have ever said this. She should have kindly asked them, said, I think a postmortem would be appropriate. Now, there are certain cultural situations where a parent might say, no, they don't want it postmortem. And to some degree, you have to respect that. And there is a fine line into, we need to find this out, and to respect the parents' cultural and various beliefs too. Again, that's an ethical situation that should be left over for the physician, but in no way should she ever approach these parents at all that a postmortem would not be required. The only time you would ever do that in an ethical situation is if you have a pregnancy situation and long before this baby is going to be born, or you have enough time before the baby is born, that the baby is going to be born with a certain situation going on, and you might just kind of want to mention to them in a very gentle way, and as a way, I don't think a postmortem would benefit, but this is a decision you can make, and I will respect it. So there are situations that it would be perfectly appropriate, but in this case, oh my God, absolutely needed that postmortem. So it says a 29-week gestation twin. Does it mention that it's a twin-to-twin transfusion and it had a blood cord, umbilical cord situation? Hell no. Lying by omission. Delayed cord clamping again. Oh, that's sending off sirens to me as a chart auditor. The reason is, I've noticed with many of these babies, they're all getting cold, honey, people. They're getting cold in the obstetrics unit, the maternity unit. Delayed cord clamping, meaning they're delaying and clamping that cord. There are valid reasons to do that, and I won't get into that. But if you have to delay, clamping that cord, cutting it, and handing it off to the pediatrician, neonatologist, to making sure it goes under a heat lamp, there are various methods you do in order to keep that baby warm. Besides respiration status, probably one of the most important things you do is absolutely under no circumstances do you let this baby get cold, period. Both in the delivery room and the neonatal unit, and I've seen far too many instances where this has happened. But also I can read in Nurse Lucy's text that she's even saying the cots are broken. So, these babies are allowed to be cold. You let a baby get cold, you're just asking for stress. You're just asking for the the body would have to shunt the blood to the major, when you get cold. Think about it. The body goes into a stressful situation. It shunts the blood away from the intestines because, you can live without your intestines for a little while. You want to shunt that blood to the major organs, to the brain, the heart, the kidneys, in order to stay alive. So that's just adding to this baby's situation. Signs of maladaptation, high glucose. Okay, baby has high blood sugar. First thing you do is you look at, why did this baby have high glucose? And one of the absolute first things you always look at is sepsis. Sepsis in a neonate, sepsis in an adult. You have a high blood sugar. First thing you always think in your mind as a physician and a nurse, you think, could this be an infection? It says bile stain aspirates. Now, bile stain aspirates in an adult and I guess certain age children it's not the big of a deal. But in a neonate, that is sirens going off. There is something going on with the GI tract. Large amount of blood, 12 mil from the NG tube prior to arrest, despite clotting being mildly deranged. Okay. Sirens again going off. Clotting factors only mildly deranged. Clotting factors should have been perfect. Clotting factors deranged, that means that baby is under a septic situation, under any stress. Anytime you're under, your body is under immense, horrendous stress, the inflammatory response goes into crazy mode. It doesn't know what to do. It starts throwing flamethrowers or atom bombs when it should just be throwing grenades into whatever that situation is. And one of the classic signs is clotting factors. You look at any hint of a clotting factor issue, and in your mind, the sirens go off, and you think, are we headed down into the road that's called DIC, which probably killed baby D? And I'm going, holy shit, at this right here. See that teicoplanin? Oh my God, that's an antibiotic. Anytime first of all, I never saw it in the neonates, ever. Okay, they may have had to. Again, we were a level 3 out of a level 4. If that baby needed that type of antibiotic, that baby was thrown over to the higher level neonatal unit. Anytime I saw that teicoplanin antibiotic as an adult, I went, holy shit. There's a holy shit pathogen here. I would immediately contact, unless our infectious disease doctors would have a good documentation into that situation as to what is going on. That is an absolute siren sign that there is some extremely nasty bacteria going on. Just for them, again, a lot of times you throw a nasty antibiotic their way because you don't have your cultures back. Sometimes it takes a couple of days of the culture, but if you're throwing that antibiotic or even thinking about that antibiotic, what's in the back of the mind, you're thinking, holy shit, nasty pathogen. And again, let's look at the second antibiotic right here. Cefotaxime, that's Ceftin in America. That's another one. I think that's a 4th generation cephalosporin. That's a big, big deal. That's not a mild antibiotic. That's another big guns too. And anytime I would see something, a 4th generation, again, cephalosporin, I'm thinking there's some nasty, and I would look down and see what the pathogen is. And that would be a good way to tell me, okay, are they going to possibly need antibiotics at home? Or they're going to be in a long stay in this hospital. And again, I was a discharge planner. I had to make sure that everything would be in place when that patient was discharged, all their needs. But also I have to alert the insurance company that there is a good chance that this patient's going to be here a while, and I would tell them the antibiotic that was needed. And again, that would be enough ammunition for me to get what we would call extended stay in that stay. And insurance company would never could second guess it. And it says, okay, so this AXA, that's abdominal X-ray, sometime before arrest showed no obvious evidence for neck. On here, they're saying cause of death is neck. Okay. Yeah. Your reports don't even match. Brewer, you so So the baby, okay, yeah, the baby didn't have neck, which would be necrotizing enterocolitis, but it didn't have neck because it had what? And it was such an obvious, I mean, any village idiot would have easily been able to recognize that this was a horrendous GI blade situation. So it says no major hemorrhage pouch for neonates currently, but not in Liverpool Women's Hospital, neither or any national guidance. Okay, that is fine. Absolutely fine. Because if there is no national guidance, you are okay. You're following you go by the national guidance. But what that is telling me here? That is telling me that having a massive bleed such as this is so freaking incredibly rare in a neonate. All right? So freaking incredibly neonate. There is no real need to have national guidance. But I can guarantee you that what the national guidance does, the babies that would be hemorrhaging would be the babies, and there would be national guidance in on that. Babies that maybe were vitamin K deficient, which is kind of again, that it's one of those vitamins that help with clotting, or a baby that is hemophiliac. And again, there would be guidelines in that too. So obviously these are kind of like, what we're thinking about here. Delayed core camping policy confirmed with staff. Ranitidine in preterm babies. Again, that probably would have been, I forgot to mention this here, up here too. IV ranitidine, that actually would have been okay to give that baby, even though I know it probably came from John Gibbs because he loved to give all babies that. And again, that is a medication you would give a caution with a preterm baby because it does lower their chances of infection. But in this situation, that is okay because that is lowers the acid, and you would want to give it in a GI bleed situation. But again, I'm looking at this. Okay, we're looking at this. This is Flagyl. It's an antibiotic. That is classic #1, and I see that. That is always tells me there's an infection in the GI tract. So that's what they're thinking. They're thinking there's an infection in the GI tract. We give this for so many GI infection things too. So that is, again, that's sending alarms off to me. So anyhow, any concerns, any questions? I've noticed some really good comments. I noticed someone just gave me a really good comment in my previous video that I'm going to be doing later on. So I do read this. And someone went to the comments such as, well, explain acuity levels to me. And I actually do. I have something that I can kind of explain to you. Why is it important if a baby has this type of a tube or that type of a tube in order to make sure that it has either 1-to-1, one baby to one nurse, or two babies to one nurse situation. So I can prove to you why that is important. But again, I gotta get my facts together. So again, whoever made that comment, I did something like an excellent. Thank you for doing that. And again, you're heading me down a wonderful alley, and I want to know what I can teach you, what I can explain to you. And make this as clear as day for you. And again, I'm just so sad. I do believe Michelle Warden did call the police and offer her wonderful expertise. And again, if Michelle Warden ever says anything then contradicts anything that I say, you absolutely go with her. My God, she would have saved the UK taxpayers millions of dollars. This is exactly what she would have explained to them, and she would have been much better explaining it to than I would be. So again, you all take care, and this hillbilly granny here you let me know whatever I can help you with, and I can guarantee you I am getting more from you than you are getting from me. You all take care.